This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. It's titled Outcomes of Endoscopic and Microscopic Transsphenoidal Pituitary Surgery, Evidence from a Systematic Review, Meta-Analysis, and Institutional Experience by Garanda and colleagues.
This is a topic that hits home for almost every skull-based surgeon. Transsphenoidal surgery, or TSS, has been our bread and butter for pituitary adenomas and sellar lesions for decades. But the debate between the microscope and the endoscope, it just doesn't seem to go away, does it?
Not at all. And what's interesting is that despite all the technological advances, recent high-quality studies have been quite conflicting. We've seen a randomized controlled trial showing no difference in gross total resection, or GTR, while a large Chinese registry study favored the endoscope after propensity score matching. Then you have an international multi-center analysis of over 2,800 patients that actually reported higher GTR rates for the microscope, though with higher morbidity.
Right. It's a bit of a choose-your-own-adventure in the literature. That's why this paper is so timely. Garanda and his team didn't just do a meta-analysis. They combined a massive systematic review of international evidence with their own institutional experience.
Exactly. They looked at 56 comparative studies covering 26,295 patients across 23 different countries. That's 13,575 patients in the endoscopic group, ETS, and 12,534 in the microscopic group, MTS. They also added an institutional cohort of 142 patients from their own center at Leipzig University.
Let's dive into that primary endpoint, gross total resection. For the residents listening, this is often the metric we care about most for long-term control. What did the meta-analysis find?
Using a random effects model, they found that endoscopic surgery was associated with significantly higher GTR rates. The risk ratio was 1.08, with a 95% confidence interval of 1.02 to 1.15.
That's a notable finding. From a surgical perspective, the authors attribute this to the endoscope's ability to overcome the microscopic line of sight. With the endoscope, you get that wider field of view, superior illumination, and critically, the angled visualization of the sellar and parasellar compartments. It allows us to see around corners that the microscope simply can't reach without more extensive bone removal or brain retraction.
And yet, Dr. Aris, some surgeons argue that the microscope still has the edge when it comes to stable depth perception and predictable anatomical orientation.
True. Microsurgery offers that bimanual dissection under direct binocular visualization that many senior surgeons find more intuitive. But the data here suggests that the visual advantages of the endoscope are translating into better oncological outcomes in the aggregate.
Now, what I found particularly interesting was the focus on perioperative metrics, specifically operative time. The authors noted that previous meta-analyses hadn't comprehensively assessed this.
That's a common gap. Time in the OR matters for hospital resource utilization and, arguably, for patient safety. What was the verdict?
There was actually no significant difference. The mean difference was only about 3.5 minutes, specifically 3.57 minutes longer for the endoscope, but the confidence interval crossed 0. So, for a practicing surgeon, the choice of technique shouldn't be based on how much time you think you'll save.
That's a mythbuster for some. People often assume the endoscope takes longer because of the distinct learning curve and the ergonomic demands mentioned in the paper. But at a high-volume center, that efficiency seems to equalize.
What about intraoperative blood loss?
That was one of the few areas where the endoscope showed a statistically significant increase. The mean difference was 44.0 milliliters more for ETS.
44 milliliters. Is that clinically significant to you in the OR?
Honestly, not really. In the context of a major cranial procedure, 44 milliliters is less than a quarter of a cup of coffee. While it's statistically significant in the meta-analysis, it's unlikely to influence hemodynamic stability or the need for transfusion. It might reflect the more extensive sino-nasal work sometimes required for the endoscopic approach, or perhaps the constant irrigation.
Let's move to safety, which is usually the deal breaker. They looked at a laundry list of complications: CSF leak, epistaxis, meningitis, diabetes insipidus, SAIAD, and visual outcomes.
And the results were remarkably consistent across the board. The rates of post-op CSF leak, meningitis, and even epistaxis were comparable between the two techniques. This is important because there's often a fear that the wider endoscopic approach might lead to more nasal morbidity or higher leak rates. This study suggests that's not the case.
They also found no difference in transient or permanent diabetes insipidus or SAIID, even visual outcomes, whether we're talking about deterioration or improvement or similar. It seems both techniques are equally safe when performed by experienced hands.
Which brings us to the institutional experience part of the paper. It's always good to see authors test their meta-analysis findings against their own real-world data.
Their cohort of 142 patients mirrored the larger findings. It reinforces that the choice of approach often comes down to surgeon preference and the specific characteristics of the tumor. The paper notes that interpretation is often complicated by heterogeneity, things like tumor characteristics and surgeon experience.
Exactly. A small midline microadenoma might be perfectly suited for the microscope, but for a macroadenoma with cavernous sinus invasion or suprasellar extension, those angled views of the endoscope become invaluable.
So, to summarize the key takeaways for our listeners, this meta-analysis of over 26,000 patients suggests that the endoscopic approach is associated with higher rates of gross total resection,
while maintaining a safety profile that is essentially identical to the microscopic approach. No real difference in operative time, a negligible difference in blood loss, and no increased risk of CSF leaks or endocrine dysfunction.
It really highlights how far endoscopic technology has come since it was first introduced to overcome the limitations of the microscopic line of sight.
It does. But it also validates the microscopic approach as a very safe and effective standard. If you're a resident, the message here is clear. You need to be comfortable with both, but the endoscope is proving to be a powerful tool for maximizing resection.
The study is Outcomes of Endoscopic and Microscopic Transsphenoidal Pituitary Surgery, published in Neurosurgical Review. A big thank you to Garanda et al. For such a comprehensive synthesis of the current evidence.
This has been a great deep dive. For our residents, make sure you look at the paper's discussion on the learning curve. It's a vital factor in why these results might vary between centers.
Thanks for joining us today on the Neurosurgery Hub podcast.
Until next time, keep learning and keep operating.